Welcome, Zoo Assembliers! My name is Zouk Azalishvili and I'm the founder of Zoo Assembly. Zoo Assembly is an online podcast for the highest yield basic science and clinical knowledge tested on USMLE Step 1 and USMLE Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zoo Assembly. Now, let's start rolling. Today we are continuing our respiratory physiology series, and this is the third series in the respiratory physiology. Today we'll talk about 6 main topics. This is oxygen hemoglobin dissociation curve, oxygen content of the blood. We will talk about the different reasons for oxygen deprivation, ventilation perfusion mismatch, and then finally we will discuss what happens to the blood oxygen content and the carbon dioxide content on the high altitude and during the exercise. So let's start with oxygen hemoglobin dissociation curve. We know that this curve, which is abbreviated as ODC, has the sigmoidal shape. And this is very important because sigmoidal shape of the oxygen hemoglobin dissociation curve indicates positive cooperativity of the hemoglobin molecule. Do you remember what the concept of positive cooperativity means? I hope you do. But still, let me remind you. Positive cooperativity means that oxygen affinity of each and every single binding site or the heme group increases after the hemoglobin molecule binds to the oxygen molecules. In other words, we know that we have 4 oxygen binding sites on each hemoglobin molecule, right? So 4 heme groups. When oxygen binds to the first heme group, this process increases oxygen affinity of the other heme groups. And this is why even a slight increase in arterial partial pressure of oxygen can cause a very, very dramatic increase in oxygen saturation, which is the proportion of hemoglobin molecules completely saturated with oxygen. Let's compare hemoglobin with myoglobin. We know that myoglobin is a monomer, meaning it's not composed of 4 different subunits. It's just one subunit, and therefore it has only one heme group. And since myoglobin has only one heme group, it does not exhibit positive cooperativity. In other words, it is not an allosteric molecule. So since the myoglobin is a monomer, it does not have the sigmoidal shape of the oxygen myoglobin dissociation curve, and therefore myoglobin is a bad oxygen transporter. This is why we don't have myoglobin as the oxygen transporter in our plasma. Myoglobin is only in muscles. This is why it's called myoglobin. And myoglobin has a much, much higher affinity for oxygen than the hemoglobin, which means that myoglobin stores oxygen really well for the muscles when the muscles need this oxygen. Okay, let's get back to hemoglobin again. We said that ODC, or oxygen dissociation curve, has a sigmoidal shape, but we should also notice that this curve can be shifted right or left, depending on the different modifications of the hemoglobin. But before we talk about what shifts this curve to the right or left, let's remind ourselves of the concept of P50. P50 is PO2, or arterial pressure of oxygen, at which oxygen saturation is 50%. In other words, this is the PaO2 at which the half of oxygen binding sites of the hemoglobin are saturated. And P50 is a very, very good marker of the shifts of this curve. So, as we will see in our discussion in several minutes, if the curve is shifted to right, then P50 will increase. And on the other hand, if the curve is shifted to the left, then the P50 will decrease. But first, let's talk about what changes the place of this curve. Anything that favors tau or T hemoglobin conformation shifts the curve to the right. And now let me tell you the causes of rightward shift. It's easily remembered by the mnemonic, which is given in the first aid. It is ace bets right-handed. And these letters indicate the different conditions which shift the curve to the right. A stands for acid. In other words, when there is increased hydrogen ion production or decreased pH, these hydrogen ions bind to the hemoglobin. Let me remind you from our previous respiratory physiology episode that histidine moieties or residues at the interface of the alpha beta globulins of the hemoglobin act as the hydrogen ion buffer. So they can bind to the hydrogen ions, and then such hemoglobin receives the tau conformation or T conformation. And we know that T conformation has a low oxygen affinity, so it unloads the oxygen. In other words, it becomes easier for the hemoglobin to unload the oxygen, and this is why acid shifts the curve to the right. And as we already mentioned, P50 will also increase. In other words, we will need the higher arterial partial pressure of oxygen in order to keep the half of oxygen binding sites saturated. Because when the curve is right shifted, it means that hemoglobin has decreased oxygen affinity. The other cause of rightward shift is increase in PCO2. We will talk about how PCO2 is carried by the hemoglobin and in the plasma later in this episode. However, let me tell you right here, right away, that CO2 or carbon dioxide can bind to the hemoglobin at the end terminals of the globin chains. And this complex is called carbamino hemoglobin because it's carb, so carbon dioxide, bound to amino group or N terminus of the hemoglobin. So carbamino hemoglobin. And carbamino hemoglobin also has low affinity for the oxygen. This is why CO2 binding to the hemoglobin right shifts the curve. Exercise also causes the right shift of the oxygen dissociation curve, and this makes a physiologic sense. When we exercise, let me pose a question to you. Does the oxygen consumption, total oxygen consumption, increase or decrease? I hope you're saying that total oxygen consumption increases because our skeletal muscles are working really, really intensively, and they have intensified glycolysis and then electron transport chain, and we know that oxidative phosphorylation requires oxygen as an electron acceptor. So we have increased total body oxygen consumption during the exercise, and in this state, we prefer having the hemoglobin molecules in the plasma which have low oxygen affinity in the periphery. In other words, we need the hemoglobin to unload the oxygen and send this oxygen to the skeletal muscle. We also have one metabolite, which is an intermediate metabolite of the glycolysis pathway. This is called 2,3-BPG. 2,3-BPG stands for 2,3-bisphosphoglycerate. And 2,3-BPG is negatively charged and it binds to the positively charged or basic amino acid residues in the beta globin chains of the hemoglobin. So just that you imagine this, 2,3-BPG molecule sits in the center of the hemoglobin. Not always, but when 2,3-BPG is increased, this is how it happens. And 2,3-BPG converts the R conformation of the hemoglobin or relaxed conformation into the T or tau conformation. And as we already said, tau conformation has low oxygen affinity. So to summarize, high 2,3-BPG causes excessive oxygen unloading to the tissues. And this fact is extremely high yield, not only from the perspective of respiratory physiology, but also from the clinical perspective of certain type of anemia. Guys, have you heard about pyruvate kinase deficiency induced anemia? I hope you did. I hope you have. And let me remind you that pyruvate kinase is one of the irreversible enzymes of the glycolysis pathway. And when there is pyruvate kinase deficiency, there is decreased ATP production by glycolysis. So, as I remember, there is net zero ATP production. And we know that for the RBC membrane integrity, we need the ATP. We need the pumps to work. And if the RBCs don't have enough ATP, then the membrane starts to dissociate and it starts to disrupt. This is why pyruvate kinase deficiency is characterized by echinocytes or the Burr cells, where we have this regularly placed small spicules coming out of the RBC membrane. In pyruvate kinase deficiency, although we have hemolytic anemia, we don't have a clinically significant hypoxia. And this this concept actually ties in to what we already discussed. When we have pyruvate kinase deficiency, all the proximal metabolites increase, right? And one of the proximal metabolites is 1,3-BPG or 1,3-bisphosphoglycerate. 1,3-BPG can be converted to 2,3-BPG by the enzyme called 1,3-BPG mutase or convertase. Therefore, pyruvate kinase deficiency causes increased 2,3-BPG concentration inside the RBCs, and this ensures that the remaining hemoglobin molecules which are present inside the intact RBCs unload as much oxygen to the tissues as they can. Okay, then the other cause of rightward shift of the curve is high altitude. And in high altitude, we know that we hyperventilate, and hyperventilation creates slight respiratory alkalosis, meaning our blood pH increases. And increase in our blood pH increases the production of 2,3-BPG. Therefore, 2,3-BPG increases at high altitude, which causes oxygen unloading to the tissues. And finally, the temperature. Whenever body temperature increases, this causes the rightward shift of the oxygen dissociation curve. The reason for this is that increased core body temperature maintains the hemoglobin in the R conformation or relaxed conformation, and it means that the oxygen can be unloaded from the hemoglobin. But also, let's make a physiologic sense out of this. Let's say that the patient has an infection with the systemic signs of the acute phase reaction, one of which is fever, right? And once the fever starts, then, as we already mentioned, we have increased oxygen unloading to the tissues. Why do you think we need this oxygen in excessive amounts in the infected tissues? I hope you are telling me that this oxygen is used by the neutrophils and the macrophages to create the reactive oxygen species like hydrogen peroxide, like bleach, which is hypochlorite, in order to kill the bacteria via the respiratory burst. So here we realized that fever actually helps us defeat the infection that has intruded the body. And this is the exact physiologic cause of why antipyretics are not given at moderately increased temperatures. So, unless the temperature is more than 38, we usually avoid giving antipyretics because having a moderate fever to the extent that patient does not feel super uncomfortable is actually beneficial. Fever means that body is fighting to the microbe, whichever microbe is invading the body, by right shifting the oxygen dissociation curve and unloading the oxygen to create oxygen, reactive oxygen species. Okay, now we have discussed the causes of the rightward shift of the oxygen hemoglobin dissociation curve. Now, what are the causes of the leftward shift? And there is one very, very easy mnemonic for this. If we have already remembered the causes of the rightward shift, now the only thing that we need to do in order to learn the causes of the leftward shift is to simply reverse everything. So in leftward shift, everything is lowered. In other words, when acid is lowered or when pH goes up, this ensures that the hemoglobin molecules are in the R conformation or relaxed conformation. And therefore, oxygen affinity of the hemoglobin increases, and this decreases the oxygen unloading. And by the way, several minutes ago, I think I said that R conformation of the hemoglobin decreases oxygen affinity of the hemoglobin, which is totally wrong. I'm sorry. So the right concept is that R conformation or relaxed conformation actually increases oxygen affinity of the hemoglobin. Okay, let's continue. Decreased PCO2 also increases oxygen affinity of the hemoglobin because if we have low PCO2, then we have less carbaminohemoglobin. And as we mentioned, carbaminohemoglobin is in the T or tau conformation. So oxyhemoglobin will be in the R conformation, right? Or relaxed conformation, which will decrease the oxygen unloading. Also, if 2,3-BPG is decreased, then hemoglobin goes from the T conformation to the R conformation, increasing the oxygen affinity towards increasing oxygen affinity of the hemoglobin. And finally, the temperature. When the core body temperature decreases, then we know that oxygen is no longer needed for the intensified metabolism of the tissues. So oxygen affinity of the hemoglobin increases and oxygen unloading decreases. And just one more thing. What do you think happens to the P50 when there is a leftward shift of the curve? Do you think it increases or do you think that it decreases? I really, really hope that you're telling me that it decreases after this 8-minute conversation about the oxygen dissociation curve, because decreased P50 means that even a lower arterial partial pressure of oxygen is enough to saturate the half of oxygen binding sites on the hemoglobin. And this is because the hemoglobin molecules have increased affinity towards oxygen. And this was our discussion about oxygen hemoglobin dissociation curve. Now we will talk about the oxygen content of the blood. Oxygen content of blood has a specific formula. Let's talk about this formula. Let's go through this formula and explain why we have these variables in the formula. Oxygen content equals to 1.34 multiplied by hemoglobin concentration multiplied by oxygen saturation plus 0.003 multiplied by PaO2. Okay, so let's start by defining what the oxygen content is. Oxygen content is the total amount of oxygen present in 1 deciliter or 100 milliliters of blood. And we know that oxygen in the blood exists in two forms. Most of the oxygen is bound to the hemoglobin, but very minuscule concentration of oxygen is actually in the plasma. So it's dissolved in the blood, and this is what's called PaO2 or arterial partial pressure of oxygen. Okay, so how do we get this coefficient of 1.34? What does it mean? 1.34 is the amount of oxygen that 1 gram hemoglobin can carry if it's fully saturated. Let's take an example. Let's say that 1 gram hemoglobin consists of 100 molecules of hemoglobin. This is just an example. That's not it's not even an approximation, but let's consider that 1 gram hemoglobin equals to 100 molecules of hemoglobin. If all of these 100 hemoglobin molecules are fully saturated with oxygen, meaning if all 4 oxygen binding sites of each hemoglobin molecule are saturated, then these hemoglobin molecules together can carry 1.34 milliliters of oxygen. This is why we use 1.34 in this formula. Well, hemoglobin concentration is hemoglobin concentration. However, let's pay attention to the fact that we also have saturation in this formula, because 1.34 multiplied by hemoglobin shows us the amount of oxygen carried by the hemoglobin in case of complete 100% saturation. But we know that saturation is not always 100%, and it does not have to be 100% in order for the saturation to be normal. Actually, the normal saturation is anywhere from 95 to 99%. So we also have the saturation for this reason in the formula. And then finally, we have the PaO2. Let me tell you right off the bat that PaO2 is a very, very small contributor to the oxygen content. And this is proved by the fact that the coefficient for PaO2 is 0.003. So you can imagine how small of a contribution comes from arterial partial pressure of oxygen. But still, why do we multiply PaO2 by 0.003? The reason is that we need all the variables in this formula to be in the same unit. PaO2 is reported in the millimeters of mercury. However, here we need the milliliters of the oxygen. And in order to convert millimeter mercury into milliliters of oxygen, this is why we use the coefficient of 0.003. Okay, we have discussed the formula, and we have discussed why we have these specific variables in the formula. Now let's talk about the concept of oxygen binding capacity. Oxygen binding capacity is the total amount of oxygen bound to the hemoglobin in 1 deciliter of blood. Let's break down this concept. We know that the average normal hemoglobin concentration in both males and females is approximately 15 grams per deciliter. We also mentioned in this discussion that each gram of hemoglobin normally carries 1.34 milliliters of oxygen if it's fully saturated. Now, our question is, how much hemoglobin can 15 gram of hemoglobin carry if this 15 gram of hemoglobin is fully saturated? And this is what oxygen binding capacity is. So oxygen binding capacity is 1.34 times the hemoglobin concentration in grams per deciliter. And we say that at the normal hemoglobin concentration of 15 grams per deciliter, we can carry approximately 20.1 milliliters of oxygen per deciliter of blood. But please, let's take notice that this 20.1 milliliters of oxygen do not take the PaO2 into account, because PaO2 is dissolved oxygen. It's not bound to hemoglobin. Okay, and then final formula here is oxygen delivery to the tissues. Now, in oxygen delivery of the tissues formula, cardiac output should be multiplied by oxygen content of the blood. And let's realize this formula, why this formula works in this way. We said that oxygen content of the blood is the total amount of oxygen carried by 1 deciliter of blood. Cardiac output is the amount of blood delivered to the tissues in 1 minute. So let's say that 1 deciliter of blood carries, let's say, 50 milliliters of oxygen. That's just an example. Then how many milliliters of oxygen will be carried by the 50 deciliters of blood? 50 deciliters is 5,000 milliliters, or 5 liters, right? Which is the approximate cardiac output in a healthy person. So 5 to 6 liters. And this is how we find this out. So we multiply the cardiac output by the oxygen content to find out how much oxygen is delivered to the peripheral tissues per minute. Okay, and this formula is extremely important for us to realize why we have, let's say, tachycardia or high output heart failure in the later stages of anemia. When we have anemia, guys, what do you think happens to the hemoglobin levels? I hope you're telling me that hemoglobin goes down. Otherwise, I think we should go back to the hematology or something. But okay, yeah, hemoglobin goes down, right? And if hemoglobin goes down, let me pose another question for you. What will happen to the oxygen content of the blood? Yeah, I agree. It will decrease because, as we said, hemoglobin is the main transporter of the oxygen to the tissues. Okay, so if oxygen content goes down, it means that oxygen delivery to the tissues also goes down. However, what do you think? How can we compensate for decreased oxygen content? Meaning, what should we increase in order for the tissues to receive the same amount of oxygen as in the case of normal hemoglobin concentration? I hope you're telling me that we should increase the cardiac output. And this is exactly why we have, let's say, baseline tachycardia in a severely anemic patient, right? Or this is also the reason why, after several years of having chronic anemia, the patient might develop high output heart failure, because the contractility and the heart rate are increased at baseline when the person has anemia in order to supply the body with normal amount of oxygen. And then the heart kind of burns out, and then contractility starts to decline just very, very slowly and gradually. Okay, we talked about the effect of anemia on the oxygen content. Now let's talk about two other conditions, and let's walk through what happens to the oxygen content and the different variables that we've talked about. And the first one is carbon monoxide poisoning. We have discussed carbon monoxide poisoning in our previous episode of the respiratory physiology, but let's remind ourselves that carbon monoxide binds to hemoglobin molecule at the site of the heme group, meaning at the site which is normally occupied by oxygen. And carbon monoxide bound to hemoglobin is called carboxyhemoglobin. Please don't confuse carbaminohemoglobin, which is carbon dioxide bound to the N terminal of the globin chains, and carboxyhemoglobin, which is carbon monoxide bound to the heme group of the hemoglobin. Okay, and we also said in the previous episode that When the CO binds to the hemoglobin, then it shifts the curve to the left, meaning it increases the oxygen affinity of the hemoglobin, right? So we know that oxygen delivery to the tissues will be decreased. Now let me ask you, what happens to the oxygen saturation in patients with CO poisoning? Are you saying that it will decrease? Then you are totally right, because just to imagine this, CO occupies the same site that's normally occupied by oxygen, right? So this is why oxygen saturation, or the amount of hemoglobin bound, amount of the hemoglobin oxygen binding sites bound to the oxygen, are actually decreased. Okay, and then we said that oxygen content will go down. Let's also talk about polycythemia. First of all, let me ask you a question. Do you remember the definition of polycythemia? Polycythemia is increased erythrocyte concentration in the blood. Not necessarily RBC mass, but RBC concentration, right? And then what happens to total oxygen content in case of polycythemia? Let's go back a little bit and let's say once again that in polycythemia we have more than normal hemoglobin molecules per deciliter of blood. So if hemoglobin concentration is increased, then what do you think will happen to oxygen content? I agree. It will increase. And as for the oxygen delivery to the tissues, it's a little bit tricky because it is intuitive to think that if oxygen content increases, then polycythemia should increase the oxygen delivery to the tissues. However, when the person has very severe polycythemia or erythrocytosis, the blood viscosity or the thickness of the blood is so high that cardiac output might actually decrease due to increased resistance to the blood flow. Therefore, it's very tricky to say that polycythemia increases oxygen delivery to the tissues. Oxygen delivery might in fact stay normal, or in case of severe polycythemia, it might even decrease. Okay, this was discussion about the oxygen content of the blood. Let's now discuss the definitions of hypoxia, hypoxemia, and ischemia. This is really high yield for step one because, as I have noticed, some of us use these terms interchangeably while this is not true. It's absolutely not true. And let's draw the line of difference between these three terms. Hypoxia means decreased oxygen delivery to the tissues. Do you remember the formula for for oxygen delivery to the tissues that we discussed several minutes ago? I hope you do. It was cardiac output multiplied by oxygen content of the blood. So it means that hypoxia can be caused by either decreased oxygen content of the blood, let's say due to hypoventilation and decreased PaO2, or anemia, meaning decreased hemoglobin. But on the other hand, hypoxia can also be caused by decreased cardiac output. Let's say that we have a patient who has congestive heart failure, or CHF. In this patient, the oxygen content might actually be normal. However, since cardiac output is severely depressed, the person will still have hypoxia, meaning decreased oxygen delivery to the tissues. And yes, the conditions that we discussed before, meaning anemia and CO poisoning, can also cause hypoxia at the expense of decreasing oxygen content of the blood. Okay, now let's move on to hypoxemia. What is hypoxemia? Hypoxemia is decreased PaO2. It's specifically a decline in the arterial partial pressure of oxygen. And hypoxemia will certainly cause hypoxia because when PaO2 goes down, when the dissolved amount of oxygen in the plasma goes down, then oxygen saturation also goes down because dissolved amount of oxygen is the one that finally goes into the RBCs and occupies the hemoglobin molecules, right? So, just to once again repeat what I've said, hypoxemia always leads to hypoxia, but they are not the same things. Hypoxemia specifically means decreased PaO2. Okay, when we have decreased PaO2, then we should differentiate hypoxemia into two different groups. We can have hypoxemia with normal AA gradient and hypoxemia with increased AA gradient. And for this, we need to discuss the AA or alveolar arterial gradient first. Let's take a step back and talk about this gradient. We know that oxygen goes from the alveolus into the pulmonary capillaries, right? And if alveolar PO2 is approximately 100 millimeters of mercury, then pulmonary capillary oxygen tension or partial pressure of oxygen should also be 100. Because, as we know, oxygen in normal situations is perfusion limited gas, not diffusion limited. And the idea is that some of the blood that goes to the lungs does not get oxygenated. This blood simply goes to the lung parenchyma and it feeds the lungs. However, it does not get oxygenated. And this is the blood which is present in the Thebesian veins and bronchial veins. And then these Thebesian veins and the bronchial veins, they drain into the pulmonary veins, which bring the blood to the left atrium. So if Thebesian vein and the bronchial vein blood has PaO2 of approximately, let's say 40 millimeters of mercury, while pulmonary capillary oxygen tension is 100 millimeters of mercury, then when they mix in the pulmonary veins, then the total oxygen tension or the partial pressure of oxygen in the pulmonary veins and then the arteries, the systemic arteries, decreases slightly. So it might be like 95, it might be 90, things like that. And this creates the gradient or the difference between alveolar and arterial oxygen. The normal AA gradient was previously said to be somewhere from 10 to 15 millimeters of mercury. However, we should be a little bit more specific. AA gradient actually depends on the person's age. In other words, the older the patient is, the higher the normal AA gradient. And actually, there is even a formula for this, and let me teach you this formula. So, in order to calculate normal AA gradient for someone, we should divide their age by 4 and then add 4 to this number. Let's take an example. Let's say that we have a 16-year-old boy who came to the emergency department with oxygen saturation of, let's say, let's say 80%. And then the blood taken from the radial artery shows PaO2 of 70. And then my question is, what is the normal AA gradient for this patient? Normal AA gradient for this patient is 16, or his age, divided by 4, which is 4 plus 4. And 4 plus 4 is 8. So for this patient, the normal AA gradient is actually 8. And now, if we calculate the AA gradient in this patient, we can actually think about the different causes of hypoxemia depending on whether AA gradient is normal or increased. And let's now talk about this. Normal AA gradient in hypoxemia means that the hypoxemia is caused something else other than the lungs themselves. In other words, the lung tissue, the lung parenchyma is intact. It's normal. It's something extraneous which then causes hypoxemia. Let's say that we have a patient who is at the high altitude. We know that At high altitude, the atmospheric pressure goes down, and even though the relative percentage of oxygen is still the same, meaning it's 21%, the partial pressure of oxygen in the atmospheric air decreases because the atmospheric pressure itself decreases. And this causes decreased alveolar pressure, and decreased alveolar pressure itself will cause decreased arterial pressure. So you can see that alveolar and arterial pressure at the high altitude decrease by same quotient, or by the same amount. This is why AA gradient will be the same. So alveolar PaO2 minus arterial PO2 will be normal. Normal AA gradient might also happen if the patient is hypoventilating. Let's say that the 16-year-old boy whose example I told you before has injected opioids, let's say morphine. We know that opioids decrease the CNS activity and they depress the respiratory center, in the respiratory medullary center, and therefore patients who are intoxicated with opioid have very low respiratory rates, sometimes dangerously low respiratory rates like 5 and 6 per minute. And when there is decreased respiratory rate, the respiratory rate does not meet the rate of CO2 production in the tissues, right? And then, oh, sorry, I'm talking about now CO2, but we should talk about the oxygen, sorry. Yeah, so the idea is that when the person hypoventilates, then there is less alveolar oxygen, and less alveolar oxygen or less big AO2 causes decreased P small AO2 or arterial oxygen. But the difference between alveolar and arterial oxygen will stay the same. Now let's talk about what happens if, so what can cause increased AA gradient and hypoxemia. So when we have problem with the lungs itself, this is when AA gradient increases. Let's say that we have person who has interstitial fibrosis due to any reason. Let's say that's idiopathic pulmonary fibrosis. In that case, we know that thickness of the diffusion membrane is increased, right? Because fibrosis is collagen, and collagen is very stiff and very thick, so oxygen has more difficult time to go from the alveolus into blood. In that case, arterial partial pressure of oxygen will definitely be decreased because oxygen has harder time going through this thick collagen barrier that it has on the way. However, alveolar oxygen pressure in this patient will be normal because there's no problem in, there is the problem because this is a restrictive lung disease, but what I'm saying is that the amount of oxygen that the patient inhales in an alveolus is normal. So alveolar partial pressure of oxygen will still be normal, approximately 100 millimeters of mercury. Hypoxemia with increased AA gradient also happens with the shunts. If we have right to left shunt, that can definitely cause increased AA gradient, and let me tell you how. Right to left shunt means that the blood bypasses the lungs, bypasses the oxygenation process from the right side of the heart to the left side of the heart. And right to left shunt can be intracardiac, meaning we can have a problem inside the heart which causes right to left shunt. Let's say that we have a reversed VSD, right, or Eisenmenger syndrome in this case. This will cause decreased PaO2 in the systemic arteries because deoxygenated blood goes from the right ventricle to the left ventricle, which then pumps that blood into the aorta and systemic arteries. However, alveolar partial pressure of oxygen in this case will be normal. Therefore, alveolar partial pressure of oxygen minus arterial partial pressure of oxygen will be increased. The same is true in case of intrapulmonary right to left shunts. I know that it's a little bit difficult to imagine. Yeah, so Every time you hear about the intrapulmonary right to left shunt, I would like you to think about the AVMs or AV malformations. AV malformation is an abnormal vasculature developed between the pulmonary artery and the pulmonary vein, and the blood from the pulmonary artery goes directly into the pulmonary vein without getting oxygenated. And then you can imagine that when this deoxygenated blood mixes with the oxygenated blood coming from the pulmonary capillaries, then in the pulmonary veins we will receive a mixture of the PaO2 values of these two blood sources. And therefore, arterial partial pressure of oxygen will be lower, will be very low compared to the alveolar partial pressure of oxygen. Therefore, A gradient will increase in this case. And then finally, we should talk about ischemia. Ischemia always causes hypoxia. However, ischemia and hypoxia are not the same things. Ischemia means decreased blood flow. And we know that decreased blood flow will certainly cause hypoxia, but hypoxia is a much broader term. So it can be caused by decreased oxygen content as well as decreased cardiac output. And then what causes decreased blood flow? Well, decreased blood flow can be caused simply by decreased arterial blood flow. Let's say that the patient is in shock, any type of shock for all intents and purposes, or let's say that patient has decompensated heart failure. In that case, the forward arterial flow will also be decreased. But at the same time, ischemia can be caused by decreased venous drainage. And I think that's a very high yield concept, and it's the concept that some of us find a little bit more challenging. Imagine the microvasculature. So we have arterial, then we have capillary network, and then we have the vein, or venule, sorry. We know that the blood flows from arterial into the capillary network and then into the venule. So if we obstruct the venule, let's say that we have this small thrombus in the venule, right? If we obstruct the blood flow in the venule, then the blood will back up. It will back up into the venule itself, then into the capillaries, which will increase the hydrostatic pressure, resulting in edema, and it will finally back up into the arteriole as well. And this blood backing up will actually interfere with arteriolar blood coming forward. So, in other words, less blood, less oxygenated blood will be able to flow forward in the arteriole, and this will definitely classify as ischemia with resultant hypoxia as well. So this was our discussion about the oxygen deprivation and the difference between hypoxia, hypoxemia, and ischemia. Okay, now we'll talk about the ventilation-perfusion mismatch. But before we talk about this, let's define these two terms. Ventilation is the aeration of the lungs. In other words, this is the amount of air that goes into the alveoli per unit time. While perfusion is the blood flow. More specifically, that's the amount of blood that flows through the pulmonary capillary per unit time. And ideally, in order for us to have efficient gas exchange, the ventilation should match perfusion. In other words, the ratio of ventilation to perfusion is supposed to equal 1. However, that's not how actually the lungs work. Ventilation perfusion ratio is rarely 1. Let me tell you that lung actually has a range of the VQ ratios depending on the segment of the lung. In the apices, or in the upper parts of the lungs, the VQ ratio is approximately 3, which means that ventilation in the lung apices is 3 times greater compared to perfusion. In contrast, VQ ratio at the base is 0.6, which means that at the base there is much greater perfusion compared to ventilation, right? Because this ratio is less than 1. And now let's make sense out of this concept and out of these numbers that we said just right now. And for this, let me pose a question for you. Okay, just let me say one thing before I pose a question, and then I will tell you a question. We know that gravity works both on blood and the air. Now, my question is, which is heavier, blood or air? I hope that you're telling me that blood is certainly heavier than air. It means that gravity has a greater impact on blood flow than on the airflow. And we know that, well, when the blood goes up into the lung apices, it moves from inferior to superior, meaning it moves against the gravity. So it's hard for the blood to go from the heart to the lung apices. That's why we have baseline low perfusion in the lung apices. And when the air goes down into the lungs, well, gravity also exerts its effect on the air, and therefore there is a slightly small amount of air in the apices than in the bases of the lung, but still the effect of gravity on the air is no way near to the effect of gravity on the blood, which means that the lung apices still receive a very, very high amount of air. Therefore, ventilation is high, but perfusion is low compared to ventilation in the apices, which results in the VQ ratio of 3. And the same principle of gravity explains why VQ ratio is 0.6 at the base. Well, the base of the lungs are very close to the heart, right? Therefore, the blood going to the bases of the lungs doesn't work against the gravity as such. And therefore we have a high blood flow to the bases of the lung. When the air goes down into the lungs, well, gravity pulls the air down into the lower lobes or the bases. However, we already said that gravity has a very small effect on air because of the because air is very light in terms of the molecular weight. And therefore, in the bases of the lungs, we have a much greater perfusion than ventilation, which results in VQ ratio less than 1, specifically 0.6. Okay, now what happens when we exercise? When we exercise, the VQ ratio approaches to 1. And let's explain how this happens. When we exercise, the cardiac output increases, right? I hope you agree with me with this. And when cardiac output increases, it forces the blood into the lung apices so that now in the apices of the lung, perfusion increases dramatically. And if perfusion increases, then VQ ratio should decrease from 3 all the way to the 1. Well, it might not be exactly 1, however, it will be very close to 1 because during exercise, the amount of blood flow going to the lung apices actually approaches the amount of air that goes into the lung apices during ventilation. And as for the bases of the lungs, well, even without exercise, there is a very high amount of blood flow in the lung bases. However, when we exercise, we know that we increase our tidal volume and we increase our respiratory rate as well, depending on our body's conditioning, and therefore ventilation itself also increases. And when the ventilation in the lung bases increases, it approaches the amount of perfusion in the bases, which will make the ratio approach 1. So it will be, let's say, 0.9 instead of 0.6. Okay, and then do you remember which microbe causes secondary reactivation in the upper lobes? Yes, this is TB. Mycobacterium tuberculosis causes secondary or reactivational TB in the upper lobes. And the reason for this is that in the upper lobes we have much greater ventilation relative to perfusion. Therefore, there is a lot of oxygen left in the alveoli, which is consumed by the Mycobacterium tuberculosis because TB is a obligate aerobic bacterium. And then we have to discuss two specific circumstances which can be considered as the extremes of VQ mismatch. Sometimes they're not even considered the as the part of the VQ mismatch because they are really the extreme cases. So on one hand, we can have a VQ mismatch equal to 0. And if the ratio equals to 0, it means that the numerator is 0, right? So numerator in this case is V, or ventilation. So when VQ ratio is 0, it means that ventilation in that particular lung segment is 0. Can you think of possible situations in which ventilation can be 0? Let's say that patient has lobar pneumonia. When we have lobar pneumonia, the exudate goes not only in the interstitium but also in the alveolar lumina. And if the alveoli are full of pus and exudate, then oxygen and CO2 exchange doesn't really happen that well. So it means that ventilation will be 0, however, perfusion will be maintained, although decreased due to hypoxic vasoconstriction, but still maintained. And we can also imagine the situation where we have a bronchial obstruction, right? Let's say that we have a bronchogenic carcinoma which completely obstructs the bronchus, then distally we won't have ventilation there. And whenever VQ ratio is 0, giving the 100% oxygen does not improve the PaO2 because let's imagine that we have two alveoli. One alveolus is open, the other alveolus is full of, let's say, exudate or transudate in case of the pulmonary edema or nephrosis or cirrhosis. The baseline is one alveolus participates in oxygen exchange while the other does not. If we increase the fraction of the inspired oxygen, in other words, if we simply give more oxygen to the patient than 21% of the atmospheric pressure, then this oxygen, extra oxygen, will go down into the functioning alveolus. However, it won't go down into the non-functioning alveolus. And the functioning alveolus is working at its 100% anyways, so it will not increase the oxygen transfer anymore. At the same time, by giving extra oxygen through increasing FiO2, we will not increase the oxygen transfer in the non-functioning alveolus. Okay, and then let's discuss the VQ ratio of infinity. When can the VQ ratio equal to infinity? This is when the denominator equals to 0. Denominator in the VQ ratio is Q, or blood flow, right? Perfusion. And can you imagine of the situation where VQ ratio can be infinity? Yes, louder. Pulmonary embolism. Because in pulmonary embolism, we have a thrombus lodged in either the pulmonary arteries or pulmonary capillary if it's a small thrombus, right? And when the thrombus gets lodged in the pulmonary artery, it just cuts off the blood supply to that particular segment or the lobe of the lung. Even though that particular lobe of the lung still gets ventilated, it does not get perfused. And in that case, the blood flow that was supposed to go into that specific lobe will be redistributed into the other lobes. So you can imagine that if we give extra oxygen to this patient, then PaO2 will actually increase, because if that blood which was supposed to go into that specific segment is redistributed among the other segments which are also ventilated, then giving this extra oxygen will actually oxygenate this redistributed amount of blood. And once again, pulmonary embolism is the classic example of the VQ ratio of infinity. And then finally, talking about VQ mismatch, we should discuss the different segments of the lungs and the relationship between the pulmonary arterial, alveolar, and pulmonary venous pressure. Let's start with the apex of the lung, or the upper part of the lung. We said that in the upper part of the lung there is relatively low blood flow due to the effect of gravity on the weight of blood. It means that out of these three pressures, the highest one is alveolar pressure, because air is the least affected medium by the gravity. So alveolar pressure is definitely high, but then second pressure is arterial, pulmonary arterial pressure, because we know that through the lungs, blood flows from the pulmonary arteries to the pulmonary veins, and blood always flows from high pressure to the low pressure, which means that pulmonary arterial pressure should always be greater than pulmonary venous pressure. Otherwise, the blood will not flow through the lungs. So in the apex of the lung, this is the sequence or the order of the pressures. Alveolar pressure is higher than pulmonary arterial pressure, and pulmonary arterial pressure is higher than the pulmonary venous pressure. Now let's go down into the middle segment of the lung. In the middle segment of the lung, the alveolar pressure still stays high. However, middle segment of the lung is closer to the heart, and therefore there is less gravity effect on the blood flow. So in the middle segment, pulmonary arterial flow is higher compared to the apex of the lung. Therefore, the highest pressure out of these three will be the pulmonary arterial pressure. The second pressure after pulmonary arterial pressure will still be alveolar pressure, and finally we will have the pulmonary venous pressure. And then at the base of the lung, we know that perfusion is maximal, right? Because the base of the lung is almost at the level of the heart, even maybe lower, which means that gravity and the blood flow work in the same direction. In that case, pulmonary arterial pressure is the highest pressure. The second pressure is pulmonary venous pressure, because once again blood flow is maximal in the lung basis. And then the third pressure becomes alveolar pressure. And there is the simpler way of remembering this pressure sequence in the different lung segments. So just remember that from the apex to the base, we start from the alveolar pressure, and then alveolar pressure jumps with just one place ahead when we go down from the apex to the base. In other words, in the apex, it's alveolar pressure more than arterial pressure more than venous pressure. In middle segment, it's arterial pressure more than alveolar pressure more than venous pressure. And then in the basal segment, we have arterial pressure more than venous pressure more than alveolar pressure. So alveolar pressure goes from the left to the right as we go down from the apex to the base. And this was discussion about the ventilation perfusion mismatch. Okay, let's discuss the response to high altitude. So when we are at the high altitude, we know that atmospheric pressure goes down, right? And if atmospheric pressure goes down, it means that partial pressure of the inspired oxygen goes down. And even though we haven't discussed this formula, I hope you know that partial pressure of inspired oxygen is in that direct correlation with the partial pressure of the alveolar oxygen. So when PiO2 decreases, PbGaO2 also decreases, or alveolar partial pressure of oxygen decreases. And if PbGaO2 decreases, then P small ao2, or arterial partial pressure of oxygen, decreases. And when we have decreased PaO2, we know that peripheral chemoreceptors get activated, especially when PaO2 gets below 60 millimeters of mercury, and then Activation of the chemoreceptors will cause increased ventilation. Hyperventilation, on the other hand, will blow off the CO2, so PCO2 will go down, and when PaCO2 goes down, this is when we get the respiratory alkalosis. And respiratory alkalosis is the acid-base disturbance which contributes the most to the altitude sickness. And then if the person so let's also discuss the other changes which happen on the high altitude. So first, since we have hypoxemia induced hypoxia, because as we said PaO2 goes down, this will cause increased erythropoietin production. Can you tell me the chain between these two things? I mean, how does hypoxia produce increased EPO? I hope you're telling me that interstitial fibroblasts or interstitial cells in the peritubular capillary bed of the kidneys are responsive to hypoxia. Whenever we have hypoxia, either due to hypoxemia or due to ischemia, they produce increased EPO, and then erythropoietin stimulates the bone marrow to produce more RBCs. Therefore, the person who lives at the high altitude will have polycythemia. We have talked about polycythemia in our today's episode, if you remember, and this will be absolute appropriate polycythemia. In other words, this is an appropriate response to hypoxia at the high altitude, and at the same time, this is an absolute polycythemia, meaning it's not only red cell concentration that's increased, but also red cell mass is increased. 2,3-BPG also increases at high altitude, and we have mentioned that point actually when talking about the dissociation curve. We said that respiratory alkalosis and generally increased blood pH, regardless of the cause, increases the 2,3-BPG production, and as we already know from our today's episode, 2,3-BPG unloads the oxygen from the hemoglobin. So this is our defensive mechanism by how we can unload more oxygen at the high altitude. There are also cellular changes as well. So mitochondrial, the amount of mitochondria increases in the cells. And can you tell me why the amount of mitochondria increases? I hope you're telling me that mitochondria is the organelle which produces ATP by using the oxygen, right? So if we have low amount of oxygen, then we have decreased amount of ATP that's produced. So we need more powerhouses, we need more stations which will produce the oxygen, which will produce the ATP, to support the person's needs. At the same time, there will be increased renal excretion of the bicarbonate, and this is the metabolic compensation of the respiratory alkalosis. Every time we have respiratory alkalosis, regardless of whether we are at high altitude or not, there is increased renal bicarbonate excretion to get rid of that extra base that we have compared to acidity. And we can actually give the patient at high altitude acetazolamide. This is an extremely high yield integration of the renal physiology and the pulmonary physiology. Can you please tell me why we can give acetazolamide to a patient who has a very severe respiratory alkalosis at high altitude? I hope you're telling me that acetazolamide is carbonic anhydrase inhibitor, and carbonic anhydrase, the enzyme itself, is present on the brush border of the proximal convoluted tubule, and carbonic anhydrase at this place is responsible for bicarbonate reabsorption. So if we block carbonic anhydrase, then the filtered bicarbonate molecules will no longer be reabsorbed in the proximal convoluted tubules, and this is how we will intensify or facilitate increased bicarbonate excretion by the kidneys. And finally, whenever we have the chronic hypoxia, So if patient lives at a high altitude and he or she has chronic hypoxia, we know that hypoxia causes vasoconstriction in the lungs, right? This is the only exception in the body that hypoxia causes vasoconstriction rather than dilation. That happens in the lungs. And since high altitude causes diffuse decrease in the pulmonary, sorry, not pulmonary, but alveolar pressure in the lungs, then there will be diffuse pulmonary vasoconstriction, which will dramatically increase the afterload in the right ventricle. So there will be a pressure overload on the right ventricle, and we will get concentric right ventricular hypertrophy, and we might even get the cor pulmonale, which is isolated right heart failure due to either lung disease, like lung disease. But still, yeah, so concentric RVH will be there at least. But this happens only after prolonged hypoxia. So this doesn't happen in day or in a week or in a month. This happens over the course of the years. And this was discussion of the response to the high altitude. Finally, we will wrap up our today's episode by talking about response to the exercise. And everything here makes perfect sense. So first of all, CO2 production or carbon dioxide production will increase during exercise. And this happens because during exercise, the metabolic rate increases. There is faster glycolysis, faster electron transport chain cycles, and therefore we will produce more carbon dioxide there. And also there will be increased oxygen consumption due to the same reason, right? Metabolic rate is increased and there is increased amount of ATP produced per unit time, and we know that ATP production requires oxygen in the electron transport chain. At the same time, ventilation rate will increase. So tidal volume will increase, also respiratory rate will increase, and this happens in order to meet the oxygen needs of an exercising person. We already discussed that during exercise, VQ ratio throughout the lungs approaches 1. And we have also discussed the mechanism behind this. Well, it's not surprising that cardiac output will decrease, sorry, not decrease, but increase during the exercise. And pulmonary blood flow will increase due to increased cardiac output. If the person exercises very strenuously, or if the person starts exercising very intensively right out of bed, then we might actually get acidemia. Can you imagine the reason for acidemia in a strenuously exercising person? I hope you're telling me that here we are talking about lactic acidosis, because whenever whenever we cannot meet the oxygen demand of the body by intensifying the electron transport chain, then what we do is to intensify the anaerobic glycolysis, and we know that the end product of the anaerobic glycolysis is lactate. This is why lactate might accumulate in a very, very high levels. And plus, if you have ever experienced the muscle cramps and pain after intensive exercise, this is actually due to lactate being accumulated in the muscle, and then it will just go away and be degraded on its own. So it's transient. Finally, there will be no change in the arterial oxygen or carbon dioxide content, meaning when the pulmonary arterial blood reaches the alveoli, there's the normal gas exchange. So in the pulmonary veins, we will have the normal PaO2, approximately 100 millimeters of mercury, and we will have normal PaCO2, which will be approximately 40 millimeters of mercury, right? However, the venous content of CO2 will increase and the venous content of oxygen will decrease. And we practically explained the reason behind this when we started talking about this issue, this topic. I mean, we know that there is increased CO2 production during exercise, and well, what drains the peripheral tissues? The veins, right? So venous CO2 content will be high, and at the same time, CO2 is produced by consuming oxygen. So if there is increased oxygen consumption by the peripheral tissues, then once again, the veins are the vessels which drain the peripheral tissues. Therefore, there will be decreased oxygen content in the venous blood and therefore in the pulmonary arterial blood. However, once the blood gets oxygenated and once the blood gets rid of CO2, every value will come back to its normal value. We have come to an end of our today's episode. Now let's summarize everything that we have discussed today. Today we started our episode by discussing the oxygen hemoglobin dissociation curves. We should know what can cause the rightward or the leftward shift of this curve. Then we discussed the oxygen content of the blood, several formulas, and the effect of different conditions on the oxygen content of the blood. We should also know the difference between hypoxia, hypoxemia, and ischemia because they certainly are not the same things. We also discussed the segmental organization of the lungs and the different VQ ratios among these lung segments. And we have also discussed two very special circumstances of VQ ratio being equal to 0 and VQ ratio being equal to infinity. We should know the examples of both of these VQ ratios. At the same time, we have discussed the body's response to the high altitude, and finally we have talked about body's response to exercise. So you can leave the voice message on this episode to let us know how we can improve our podcast for you. So thank you for your kind attention, Zoos and Maliers, and see you on the next episode.